our OPQC webinar. My name is Susan Ford. I'm the Quality Improvement Consultant with the Ohio Perinatal Quality Collaborative. We can go to the next slide. We've been doing these COVID response webinars on a weekly basis since March 27th. And so for those of you that were on our very first COVID webinar, you'll recall that Dr. Bill Schnettler presented on a patient of his that was in the ICU at Good Samaritan Hospital. She was pregnant. At this point, the patient has delivered. The baby is in the NICU, and their work has been published. And today, the team that cared for this mother-infant dyad, cared for this family, are going to share their lessons learned and share their responses and reflections to the case. Additionally, we have Heather Lords, who is the perinatal safety nurse at the Ohio State University Wexner Center, who will be sharing their work there with COVID-specific simulations. So we're very excited to have our presenters on with us today. We can go to the next slide. And again, I know I've said this in the past, I do think everybody is a Zoom expert at this stage of the game. I will stop though and ask that everyone to be certain that you do utilize your participant code if able. You are able to do that by, if you've joined without a participant code, you can hit pound the code that is assigned to you and then pound again, and that will link your number and your email registration here, which would be very helpful. I also want to mention that the call is being recorded, and we will be posting both the recording and our slides to our OPQC website should you have some colleagues that also wanted to attend but were unable to. We can go to the next slide, please. We do group meet the lines with a large number of attendees, but really want this call to be interactive. So please do utilize the chat box throughout the call. We want your comments, your questions, your reflections. Please feel free, but we will be stopping periodically throughout the presentations to take questions. And like I said, we really do want this to be interactive. We can go to the next slide. And in the spirit of and structure and foundation of perinatal quality collaboratives, our goals today include sharing practicalities of implementing strategies right now in response to the COVID outbreak here. We want to learn what other people are doing where there is not yet guidance or it is unclear, and really embrace the all teach, all learn approach that is inherent to quality improvement. We had over 200 registrants today, lots of several submitted questions, and today's focus, like I mentioned earlier, will be that case study of the critically ill COVID positive patient and her infant. And then we also want to tie into that the benefit of the debrief and simulation. And we're looking at that from the lens of a specific COVID-19 setting. And again, the slide deck will be available on our website. We also have, our project management team has done a fabulous job of updating resource lists on our website, and it's been parsed out into care for the pregnant patient, care for the infant, information for breastfeeding moms, information for pediatrics. I really like the way they have set it up, and that is being updated regularly and frequently as guidance does change. And lastly, I just want to state that the case scenarios that are shared today are individual institution. They're not OPQC recommendation. From that, we can go to the next slide, and I will turn it over to Dr. Heather Kaplan. She is our OPQC Neo faculty, and she's going to share some very important COVID neonatal registries here when we're talking about data collection. So Heather, I'll turn it to you.
Thanks, Susan. So I just wanted to put another plug in or a reminder for folks about the various options that are available for participating in registries to gather data on the impact of the COVID-19 pandemic on pregnant moms and babies. Obviously, as we try and make and people in power try and make database decisions, having this kind of information is really, really helpful. So one opportunity to make sure that everyone is aware of is a registry that's being supported by the AAP section on neonatal perinatal medicine. It's collecting data on mom-infant dyads in which the mom had confirmed COVID-19. As of right now, they actually have 44 hospitals that are starting to submit data, 38 who are in the process of IRB submission and completing DUAs, and 20 who've expressed interest. So that would be a total of 102 hospitals that are generating information, which would be really amazing to learn. And 3 hospitals in Ohio have signed up to participate in this, but I think we could do even better. So please see the link at the end of the slide to sign up. Mark Hudak, who's the president of the section, is happy to talk to anyone by phone, or his email is here if you have questions. But I think it would be great to be able to get more Ohio hospitals participating so that we could even think about carving out some of the data for Ohio to look at the impact specifically here. So see that link at the end of the slide deck, and please seriously consider signing up. Next slide. There also is an option for a slightly different type of approach to collecting data on the impact of COVID-19 on neonates, and this is a joint effort by Vermont Oxford Network, or VAUGN, and the AAP section. And again, here the goal is to inform the local and national decision-making for both program evaluation and quality improvement. And I had misspoken when I presented this opportunity before, that it was only open to hospitals that participate in VAUGN, but it's actually open to any hospital that cares for infants. So at the end of the slide, there is a link for you to sign up for this. There's also opportunity to look at our data locally if we have enough sites in Ohio participate. And right now they have over 90 NICUs that are participating in this registry, but still an opportunity to sign up for doing the audit through the end of the month. Essentially, the goal is to complete this audit in April for the first time. So please see that link to sign up. Next slide. And I'll turn it over to Mike to talk a little bit about the obstetrical opportunity.
Hello, everyone, and welcome to OPQC webinar. So just so everyone's aware, there is a registry that is being conducted to collect data on pregnancies in patients with known or suspected coronavirus infection. And as of yesterday, they have enrolled 300 women. And we are encouraging anyone who has a known or suspected COVID-19 infection in pregnancy patient that they link to this registry and enter their patient information. If you have any questions, please don't hesitate to reach out because I think they are working on it. It looks like Dr. Rubenstein from New Jersey has put in quite a bit of information about their patients. So it's really important that we do continue to enter as much as we can into this. So next slide. As we've done every week, I just wanted to review the numbers again. And this is as of yesterday. From the world perspective, we're over 2 million confirmed cases and over 140 confirmed deaths. We do believe that because of limitations in testing in most places in the world, that we're underreporting the incidence. That also goes for the United States. We are now over 630,000 cases. And in Ohio, we believe that we're in the flat part of the S-shaped curve and have just passed 8,400, 707 ICU admissions, and 389 deaths as of yesterday. So I just wanted to point out one thing. The map in the middle for the United States is not the most current map that's on the CDC website, but many states are starting to turn that dark shade of red, which indicates more than 10,000 cases in those states. So next slide. The other thing I wanted to do is we have been asking you all to list the number of cases you've had, and in OB patients, the numbers every week have gone down for no cases, and the number of cases that are going up for 1 to 5, 6 to 10, and one, it looks like one center probably has greater than 10 cases recorded for this past week in our registration. Next slide. We also were looking at how many newborns have been tested, and again, the rate of no testing at your site has gone down, and the rate of testing has increased with each week, presumably because the number of infants born to mothers with suspected or confirmed COVID-19 infection has continued to increase. And then the last question that we asked on the registry is how many moms do you have in the ICU with presumed or diagnosed? And again, the same kind of message where we are down to about 60% of sites still not having any moms in the ICU, but a few centers having more than 5, and the majority of our centers having a few maternal cases in the ICU. And that really brings us to our presentation today about a specific case that happened really when in our center in Cincinnati, we first started to see maternal cases of COVID-19. One of our patients became critically ill. And so next slide. I'd like to take this opportunity to introduce Dr. William Schnettler and Dr. Anju Suhag, who are both my partners in maternal fetal medicine, and they cared for this patient. Our paper was just recently accepted this week to give an example, and we'll go through that here in the next 10 minutes or so. So thanks a lot for taking time out of your very busy days, and I'll turn it over to you, Dr. Schnettler.
Good morning. Can you guys hear us?
Oh, there you go. Yes, indeed. Wonderful.
Great.
Thank you.
Hey. Good morning. So thank you, Mike, for the introduction. So I have both myself, I'm Bill Schnettler, and Dr. Suhag, Anju Suhag, right here with me. And we're going to present together. We had the opportunity of presenting this case a few weeks back, back when things were still a little bit in the infancy of the case, no pun intended. So we'll kind of speed through the initial presentation and talk more at length about kind of the management and really critical decision making pieces that I don't think we had really gotten to during our last call. So if you remember that this was a case of a 39-year-old woman, Gravid 6 para 2031, who presented actually on March 20th, or initially to our emergency department, just shy of 31 weeks, with some symptoms that were somewhat suspicious of COVID, but her workup through the ED was relatively non-conclusive, and that she was sent home having had a nasopharyngeal swab for COVID-19. She represented on March 24th, and at that point was already in the severe stage of ARDS. On initial presentation, her oxygen saturations were reasonably controlled on some nasal cannula oxygen, but really within the span of about 9 to 10 hours, she deteriorated quite quickly and required rapid sequence intubation and really maximal dose, maximal setting mechanical ventilation. And she was really, for the first 24 hours, fairly unstable, requiring pressor support, and like I mentioned, a lot of concern spent around not only the fetal status, but her ability to oxygenate, which is kind of really characteristic of this disease. And repeat blood gases showed that she was meeting criteria for critical ARDS with a P to F ratio that was under 150. So she, at that point, we were really needing to think outside the box and started considering manually proning her, which we did, and that seemed to really help and allowed us to drop her FiO2 and her vent settings quite a bit. She went for several days spending about half of the day in a prone position and gradually trying to increase the amount of time that we could get her in her left lateral decubitus position, and had initiated medications including hydroxychloroquine. We kept her on oseltamivir, which was what she had been on prior to her arrival, and we initiated broad-spectrum antibiotics to cover a possible coincident bacterial infection. We actually applied for permission for compassionate use of remdesivir, which we achieved, and we initiated the remdesivir. And really for the first week, really tried to support her as best as we could without needing to intervene on the fetal behalf. She did make some gains, and we were able to not need to implore the utility of ECMO or inhaled pulmonary vasodilators. However, on her hospital day 8, the baby started to demonstrate late decelerations, and persistent uterine contractions were identified, such that we felt that we were beginning to witness fetal intolerance, and we pulled the team together, had a huddle, and effected delivery, which went very well. We were able to maintain her vent circuit and maintain as much staff protection with full PPE and mitigation of exposure to the best of our ability. Delivery went well, and baby did very well. Actually, amniotic fluid and swabs off the neonate were negative for PCR, and baby was able to be extubated on day of life 3. So we now still hospital day 23, or I'm sorry, ventilation day 23 going into 24, hospital day 24. She is still intubated in the ICU. She did get a tracheotomy yesterday, and the goal there is to be able to diminish and decrease and hopefully stop completely the amount of sedatives and narcotics that she's requiring while she had the endotracheal tube in place. Now that she's had the tracheotomy, hopefully we can start to liberate her from the vent and get some physical therapy, ambulation, etc. going to really try to help boost her recovery and get her back to 100%. So not quite there from the resolution that we had hoped the last time we talked, but we do have a healthy baby that is in his dad's arms, and I'm going to turn things over to Dr. Suhag to kind of discuss the critical aspects of the care and some of the settings and vent settings and delivery decisions that were really kind of paramount. So we can go next slide.
Great. Hi, this is Anju Suhag. Can you all hear me okay?
Yes, thank you so much.
Great. Next slide shows the critical care goals, and also this table is available in our publication that Dr. Marcotte showed earlier. Just to highlight on the big points here on this table, our goal is to keep the maternal hemodynamics as normal as possible to support the utero-placental perfusion. And in terms of the MAP goals, we have more than 65 millimeters of mercury as the MAP goals. And if necessary, to maintain those goals, pressor support could be utilized. And we used Levophed for our patient, and it could be titrated as needed, and that's considered safe to use in pregnancy. In terms of the oxygen saturation goals, the goal is to keep it about 95% and optimize the maternal oxygen delivery as necessary by the vital signs. In terms of the oxygen levels on the ABG, the goal is to keep the oxygen levels about 80 millimeters of mercury and do the setting adjustment if necessary, whether the patient is on non-invasive support for the respiratory issues or is on vent support. And then for the PCO2, the goal is to keep it under 40 millimeters of mercury, and to keep in mind that there's respiratory alkalosis as a physiological change in pregnancy. There are pH goals listed there, bicarbs and iron gap. It's all there on the table. The goal is also to keep an eye on the urine output and make sure that the peripheral, there's good urine output there, and to watch for any skin breakdown. DVT prophylaxis, I think it's really important. Just wanted to emphasize that we did heparin for a patient who Dr. Schnettler just described. She was on 10,000 units BID of unfractionated heparin because of course, increased risk of thromboembolic events, her being pregnant and with a history of stroke in the past from OCPs. Also, with the COVID illness, there are reports of increased thromboembolic events, increased risk of microthrombi as well. So our goal was to give her the third trimester dose for unfractionated heparin, and also with the thought process that if delivery was indicated, we could easily reverse that if needed. GI prophylaxis, that is done for all critical care patients. And in terms of fetal monitoring, if the mom is critically ill, unstable, of course, it's important to optimize the mother, but also look at the fetal monitoring to see if through the fetal monitoring, if we could optimize the maternal status any better. Of course, we'll go into a little bit more about the delivery considerations to not intervene in an unstable mother. So I just wanted to repeat that, not to deliver an unstable mother, and optimize the maternal status before intervening for fetal indications.
Next slide.
So in terms of delivery considerations, again, it's a busy table, but I think it really goes by gestational age, maternal status, whether the mom is critically ill or she is severe COVID pneumonia and not critically ill. So I will just for the sake of conversation here, our discussion, I'll divide it in between critically ill, and we are assuming the mom is stable, as we discussed earlier. Unstable mom, do not intervene, do not deliver, and stabilize the mom, and then reassess the whole situation and individualize the plan on a case-by-case basis. For this, I'm talking first about the viable gestational age between 24 weeks and about, actually. So between 24 and 34 weeks, and I think this would also apply beyond 34 weeks as well, for a mom who is stable but critically ill. The goal is to stabilize the mother, treat the mother, optimize her respiratory status, and support the multi-organ function. If delivery is imminent within a week, betamethasone for fetal lung maturity could be considered. There are reports out there about discussion of steroids and increased morbidity for the mother from respiratory standpoint. Again, with the thought process, potentially there could be delayed clearance of the virus with steroid exposure, but so far SMFM, ACOG, and we also followed the same, that if it was necessary, we will administer betamethasone, and that's what we did for our patient. Magnesium for neuroprotection can be considered under 32 weeks gestation if we think that by the risk-benefit analysis that it's necessary, and if there's potentially some benefit, then at the same time monitor the mother for pulmonary edema. So again, just a case-by-case determination, but consideration can be given to magnesium sulfate for neuroprotection. If the mom is in active labor, a critically ill mom who is stable in active labor, the goal would be to proceed with delivery in the ICU. If she's not in labor, again, a case-by-case assessment to understand if delivery is really indicated at that time. And the discussion and the thought process behind, really proceeding with delivery versus waiting and stabilizing the mother is really the key there. So I think our table kind of goes into more detail about all of these scenarios. In terms of delivery location, if it's a perimortem indication, do not move the patient and proceed with the C-section bedside. All we need is a scalpel and really not much assistance there, pretty much scalpel going down to deliver the baby. And of course, then the uterine evacuation would help with the maternal resuscitation. If the delivery is indicated more for worsening respiratory status of the mother and or persistent category 2 tracing, of course, with the multidisciplinary discussions and whatnot, the determination should be made where to deliver this patient. This is all about critically ill patient. In terms of mode of delivery, I just want to touch on that a little bit. If there's not an obstetrical indication, COVID-19 is not an indication to deliver via C-section. So if the patient is in active labor, the goal would be to really manage the labor as if we manage for non-COVID patients. And so far from what we understand that COVID-19 is not secreted and or at least present in the vaginal secretion from the limited data we have, and also we tested our patient, her vaginal secretions, and that was tested negative for COVID-19 just for academic purposes, since just wanted to have that understanding since we were also getting a surge of a couple of other COVID patients. So in terms of mode of delivery, again, C-section will be only for OB indications, and if the patient is a candidate for vaginal delivery, proceed with vaginal delivery. I think I want to leave it up at that, and rest is all described in the table beyond 34 weeks versus pre-viable gestational age, whatever viability cutoff your institution may use, whether it's 23 weeks, 24 weeks. Again, case-by-case determination there. Again, just the priority is if it's a sick mother, the mom gets the priority there. That's all from my side.
Thank you, Dr. Suhag. Could we go to the next slide, please?
Yeah, this table just shows kind of the patient's clinical course, and this is from the publication, but we just wanted to share that we had a lot of discussion with Dr. Bergella, who's the editor-in-chief of the AJOG MFM journal, and this sort of table had been present in a lot of publications on COVID, both in the really in the non-pregnant population, and so he was real interested in having us present kind of her symptomatology and her course in this sort of chart, anticipating that this is kind of what we're going to be seeing from other publications moving forward, to really highlight kind of the symptoms that present and the time frame from which we see rapid development of critical illness and need for invasive ventilation and medications, et cetera. So here we are, we're actually beyond the table today. We're at day, COVID day 27. So we are still unfortunately on the invasive ventilation and severe ARDS ICU admission extended out beyond this, but just a table highlighting that. And then I think we have a picture of the husband and the baby, who I just was seeing 3 minutes ago, talking with him, and he was holding his little boy Laith, and they're doing great, just still fighting for hope and prayer that she's going to pull through and recover.
Thank you so much, Dr. Schnettner, and also Dr. Suhag. That this is an amazing case here, and so grateful that that we're able to see Dad and the little one doing well. There are some questions in the chat box specifically around proning the patient, and also about retesting mom to see if she's negative prior to the trach. And I'm wondering if you could go ahead and respond to those in the chat box, and we're going to move on to the next slide and hear from the next team member on this case study. Renee Napier is the neonatal nurse practitioner who was at the patient's delivery and has cared for the infant in the NICU. So Renee, I'll turn it over to you to talk about some transitions of care here. You may need to come off of mute with *6.
Thank you, Susan. So I was fortunate enough to be present for this delivery, and a couple things. Fortunately for our center, we had known of this mom being in the ICU, and so we were able to spend some time to have things set up, I believe actually on her admission to the hospital. So plenty of things were already set up in terms of where this delivery would happen, which happened to be in our main intensive care and possibly in the main ICU and also in the OR, the main OR. So we did have beds set up and ready for baby in the event. That specific evening, the transition from OB side to NICU side went very well for us. We did have a multidisciplinary pre-brief huddle that was led by Dr. Schnettler and Dr. Suhag, including OB, anesthesia, respiratory, nursing, NICU, operating room staff. It was complete specialties there, which was incredible. The other thing is then we did break from that multidisciplinary huddle and did a NICU specific pre-brief huddle with myself. We happened to have a NICU fellow on that night. We had only 3 RNs that we took down, one of them that was going to be the main nurse caring for the baby, as well we had a documenting nurse and then a medication nurse, and then we took 1 respiratory therapist. So all roles were assigned prior to the delivery. It was a very much a planned process. The approach we took was a 2-tiered structure that was adapted for our use initially from a University of Washington algorithm that one of our neonatologists, Dr. Dana Premer, worked hard to adapt to our program. And really what it does is it limits the number of people exposed to mom, as well as limiting the number of people exposed to the baby. In this specific instance, the original plan was to have no NICU staff in the delivery itself and have the OB nurse bring the baby to the adjoining operating room through the anteroom to the NICU staff in order to limit NICU staff from being exposed to mom. In this specific instance, we did have 1 NICU member in the delivery to catch the infant. It was thought at that time that it was better in the situation of understanding what was happening in the delivery itself. So there are some discussions back and forth about what would be better from a quality standpoint there. We also then, in the resuscitation room that adjoined the operating room where mom delivered, it was just the provider and the respiratory therapist in full PPE to resuscitate the baby, with the remainder of the NICU staff outside of the resuscitation room. That would limit our use of PPE given the shortage and also limit direct exposures to baby in the event that any aerosolized procedures would happen, which they indeed did. So if you could move to the next slide, please. So the baby did end up intubated at 7 minutes of life for some secondary apnea. And outside of, once the baby was stabilized there, heart rate came up beautifully once we intubated. And from there, the infant was placed into the isolette, which was outside of that resuscitation room. And it was covered in plastic for the transport in order to limit the aerosolization. Despite having the double-walled isolette, the plastic also covered the little portholes on the side for us. The admitting nurse was in full PPE, and she was the only one to have direct touch on the infant during the transport once the baby was placed in the isolette by the provider from the resuscitation room. We then used, obviously, our back patient elevators, and then we came in through the back doors of our NICU in order to limit transporting through the NICU. When the infant then came into the room, it was only the respiratory therapist and the NICU in the reverse airflow room. Contact and droplet precautions, the baby remained in that until 2 negative tests 24 hours apart. The baby was bathed immediately with the thought that should any fluid or secretions be positive, that we could limit potential spread to baby. However, I do know there has been some discussion in other reports about the benefit of keeping vernix. So I think at this point, that is also a discussion of which may be better or worse in any scenario. But I think, again, it would need to be a case by case, as well as the criticalness of the baby that you are admitting as to whether a bath immediately is warranted. In terms of communication then from the reverse airflow room to, again, limit PPE and also limit the amount of people exposed in and out, we use baby monitors for communication, a video monitor, so that the nurse outside of the room, even though the windows are clear there for hearing things, you can see the baby as well as communicate back and forth in and out of the room. And as long as our staffing ratios allow for it, we do one-to-one nursing care with this baby. So this baby actually, I'll give you a quick overview of how the baby did, was initially NPO, thought to have some decreased motility with some bilious emesis, but feeds started on day of life 6 and started to PO day of life 15. So he is working on that currently. As was previously stated, he did extubate to room air on day of life 3 and did well with that. He was on caffeine briefly. That was more of an empiric treatment so that when he extubated, we could hopefully not guarantee, but improve his likelihood of not needing to be reintubated or need any other aerosolized respiratory support. From a cardiovascular standpoint, he did very well. He did get an EKG day of life 12 due to the known that in maternal use of hydroxychloroquine, there can be prolonged QT, and so unknown in the baby. And so he did get an EKG. He did not have any hematologic concerns. From an ID standpoint, his birth swabs were negative. That was a learning point for us, that we did not need to do them right at birth, that they are actually at 24 and 48 hours. So he tested negative. He is currently out of isolation and his blood cultures were negative as well. He also had a head ultrasound done on day of life 13, which was normal given mom's previous medical background. Other things for him from an ophthalmology standpoint, hydroxychloroquine is known, it does cross the placenta, and in some animal studies there is eye damage with the retina. And so he did have an eye exam, which was normal on day of life 13. He will probably be followed up with that. And then just from a social standpoint, we did call mom with updates for the baby, despite discussion of whether she was cognizant of and hearing. However, the labor and delivery nurse did call me and let me know that after she delivered, she told the mom the baby's weight. And she said the mom got a little smirk on her face, and her exact words were, "and big crocodile tears came down from her eyes." And so I think very important to remember that despite what we think about mom's cognition or abilities to communicate, that hearing is there. And so we did make it a point to call mom with updates for baby's weight. We also did laminate pictures for mom and sent them down to the ICU in the event that mom did or was able to open her eyes, or as mom would be waking up from her medications, that she could possibly see her baby. And we laminated them because then they could be cleaned as a nursing consideration. They could be wiped off, but mom could still keep them. In terms of—
Renee.
Yes.
Oh, Renee, thank you so much. I'm going to go ahead and ask, there are some questions in the chat box specific to testing of the baby, and I'm going to ask if you wouldn't mind addressing those in the chat box, if you could reply to that. And I'm going to go ahead and transition to Dr. Jennifer Brady while you're doing that, who is the Associate Director of the Neonatal Intensive Care at Good Samaritan's NICU, and we'll go ahead and transition there. Thank you so much for the overview. It sounds like very concrete, helpful information.
Thank you.
Thank you.
Dr. Brady.
So Yes, can you hear me okay?
Absolutely, thank you.
So I'm going to briefly review the visitation and communication aspects of this case from the NICU perspective, and you've already heard some great information from Renee about some of the things that we did to try and help communicate with this case. And then I'll briefly present our current visitation policies and communication goals based on the lessons learned. So when initially approaching this case, we wanted to promote parental bonding as much as possible, while also ensuring safety for patients and staff. So the policy in place at the time of this infant's delivery stated that a close household contact of a known COVID positive patient was not allowed to visit the NICU until 14 days from the last contact, which in this case was the mother. The dad had last seen mom the day of her admission, which was approximately a week prior to the infant being born, meaning that the dad would be unable to visit his child in person until approximately 1 week of life. At the time the decision was made to deliver the infant, there was initially some confusion regarding dad's ability to visit the infant right after birth. Our policies were new, everyone was learning, and given that dad did not have symptoms at the time, some confusion existed. However, after clarifying the policy and reasoning behind the policy with dad, although he was sad, he stated that he really completely understood why he couldn't visit at that time. So the team continued forward with a plan for dad to visit after 14 days from last contact with mom. As that day approached, it was questioned if other criteria for dad to visit should exist due to the fact that dad had previously had mild symptoms that could be consistent with COVID, although he was currently asymptomatic. So we decided to have dad undergo COVID-19 testing at that time, due to the fact that the testing at the time it was drawn was still taking many days to result, and dad was approaching his 14 days from last contact with mom. We compromised on having dad start to come visit the NICU while results were pending after he reached that 14-day period. He did wear a surgical mask, which had become standard for all visitors to wear in the hospital by that time, and dad's COVID testing did eventually return negative. During the time when dad could not visit in person, the team worked very hard to enhance communication and infant bonding as much as possible. So it's fairly standard for all patients. The medical provider and bedside nurse continued to update dad via phone, but attempted to do it on a more frequent basis. Despite limitations at the time with available equipment, the team was able to facilitate video communication between dad and infant via phone. And then with dad's consent, the team was able to take pictures of the infant and send them to the dad electronically. Communication with mom, which as Renee mentioned, was very limited due to mom's critical condition, but the team did an excellent job of printing and laminating pictures to put in the mom's ICU room so that she was able to see them when she was able to. So despite restrictions on visitation and barriers to in-person communication, dad continued to voice appreciation for the team's efforts and complete confidence in the medical care his child was receiving. Next slide, please. So as you can imagine, there were many lessons learned from this case. This slide represents our modified visitation policy for COVID based on these lessons, as well as evolving guidance from the AEP and Cincinnati Children's Hospital. Our general NICU visitation policy during COVID remains unchanged. So during the pandemic, visitation is restricted to the infant's 2 bracelet holders. No visitors with confirmed or suspected COVID-19 or close contact to confirmed or suspected cases are permitted to enter the NICU. Criteria for when these parents can resume visitation is based on whether or not they're symptomatic or asymptomatic. So an asymptomatic partner may visit the NICU 14 days after last exposure to the COVID positive patient, or in this case, the mother. We have now aligned our requirements to visit for both COVID-19 positive mothers as well as for symptomatic household partners, even if they did not undergo initial COVID testing. They can not visit until they meet all 3 of the criteria listed. So they need to have resolution of fever without antipyretics for 72 hours, as well as improvement, but not necessarily full resolution of respiratory symptoms. And then once those 2 criteria are met, 2 consecutively negative COVID-19 tests collected at least 24 hours apart. Hospital infection prevention has agreed that testing these symptomatic partners is warranted given our vulnerable NICU population. And we're lucky that our OB-MFM colleagues have graciously offered to take on the task of ordering tests for mom's partner when it's warranted. Next slide, please. So although the team did an excellent job with creative solutions to enhance communication and parental bonding during the case discussed, we want to do better. And so this slide presents recent recommendations from Cincinnati Children's Hospital for enhanced communication and bonding between parents and infants when visitation is not possible due to COVID. We are working to try to be able to meet these suggestions for if and when another case presents. And the goals are listed here, and some of them are already standard of care, but nursing updates to parents every 3 to 6 hours, so more frequently. Video connection between parents and infants, ideally every 6 hours. Provider daily updates to parents via phone or video chat. And then a daily photo of the infant provided to the parents, either printed or digitally. Thank you.
Thank you so much, Dr. Brady. That was very helpful. I was speaking with Dr. Greenberg last week from the Perinatal Institute there at Cincinnati Children's just about the changes that are being implemented and not going back to what normal used to be. And his words of wisdom were, what can we learn from this and how can we improve care for our patients? And I think that that's exactly what you've done here, to go ahead and learn from this situation and what can we do to support family-centered care and parents and keep the NICU a safe place for our caregivers and for our babies, our patients, while supporting the family. So thank you very much. We have had some questions that have come in on our registration form about bathing the infant, and I'm wondering if you wouldn't mind just chatting into the chat box recommendations. I know that you and Renee touched on that, so if either one of you could do that, that would be very helpful. I'm going to transition to the next slide, and an important part of this this whole case is the debrief that occurred after this event. And I've been speaking to the team, and there are two individuals who are going to briefly share their reflection on the ability to participate in the debrief. Carolyn Sloan is the nurse manager at Good Samaritan Hospital for labor and delivery, and Kathy Boss is the neonatal intensive care nurse who cared for this baby at delivery for the resuscitation with Renee, and also participated in the debrief. Carolyn, can I have you come off of mute and share your reflections, and then we'll hear from Kathy before we move to simulation?
Sure. Can you hear me?
Yes, absolutely.
Okay, thank you so much for giving me the opportunity to speak. This was a great experience, all things considered. And the debrief is such an opportunity to learn from that. And what we learned, there are lots of great things that we learned. One, we were very prepared. The information that was shared from the providers and the whole team on the briefing from the day before when we talked about the case and then the day of the case was fantastic. Everybody felt very prepared. But what we were not prepared for was the time when the case occurred. So because this case occurred at the change of shift, we had a great deal of people in that OR, and that's what came out of our debrief. One of the major issues is that, you know, what team takes over that case? Is it the OR team or is it the OB team? And so there were probably more people in the OR than was necessary. So, you know, moving forward, we decided that it was probably best if we identified one OB team that would go to the OR, the main OR, to deliver these COVID patients or care for them in our COVID unit. And so we have, from this point forward, identified one team every day that would respond to these cases. And that has really helped us control the use of the PPE, keep these people, you know, emotionally in the game because it is very stressful. So we know in advance who those people will be, and we can assign them and work together with the main OR. During the day, they have more staff in the main OR than they have at night, so OB doesn't really change. We're consistent, and so we can have a consistent message with our team, and then, you know, provide the best care possible to our patients. One of the other issues
that's, oh, I'm sorry, Carolyn, a great takeaway. That is so important. And I'd like to hear from Kathy also from the neonatal standpoint.
All right, can you hear me?
I can, yes.
Okay. Hi, it's Kathy Wassi from the NICU, and I was the charge nurse on that night, so I was actually the med drawer in the hallway. But the debrief that we had was amazing. It was a little bit harder because most of the team was night shift that was at the delivery, so having management and night shift meet all at once, as everyone knows, is always a little more difficult. So the telecommunications with COVID actually helped the debrief to be to include everybody, and we needed management on because we made some of the process changes that Renee and Carolyn just spoke of. It also helped with like the emotional aspect of like the sense of accomplishment, because we did do everything as we planned. We had multiple pre-meetings right before the delivery with each individual team and a team as a whole, and the entire thing went exactly as we had planned and was very smooth, and that was definitely a huge accomplishment and a takeaway from the debrief, and brought closure to that delivery, but encouragement for future deliveries and as we progress through this. So it was definitely a different type of debrief, because obviously you don't always do them in positive cases and have so many people involved, but it was overall very positive and encouraged to do in the future.
Thank you so much, Kathy. That is wonderful feedback, and that truly is the goal of the debriefs, right? To go ahead, come together, learn from it, and then move on, making those changes. So thank you very much, both Carolyn and Kathy, for sharing their feedback. I'm going to go ahead and transition to the next slide and turn it over to Heather Lortz. She is the perinatal safety nurse at the Ohio State University Wexner Center, and she's also the Central Ohio AWINE representative. They have done some work specific to simulation for the COVID patient, and we are hoping to learn from you, Heather. So I will turn it to you.
Thanks, Susan. Thank you so much for inviting me to share the work of our group. I'm absolutely humbled and pretty stunned by the previous presenters on this call. Your work is amazing, and as a perhaps slightly over empathic kind of personality, I've had moments here on this call of trying to like keep myself together and ready to present. That's what you've done for that patient and that baby are absolutely outstanding. Go to the next slide, please. So why simulation in obstetrics? And I think in the interest of time, I'm going to be pretty brief with this slide. We all recognize that our guidelines for perinatal care, as well as many of our obstetric professional organizations, certainly advocate for the use of simulation in both emergency procedures and routine procedures, because we know that simulation improves patient outcomes. The old adage, practice makes perfect, definitely applies here. But I think despite the struggle with accomplishing our regular drills, the fact is no one really wants to take a stressful day on a unit and spring a practice drill on a staff. And I think that applies to this situation as well. But with that in mind, compounded with the very real feelings of anxiety and fear that some of our staff members have when it comes to contemplating the care of this COVID population, we knew that it would be really important for us to provide the staff with a specific workflow to use and to practice that workflow together to maximize efficiency and preserve the health and well-being of our patients and staff. We're in a pretty unique moment in healthcare right now, I think, in this country. Drills historically have focused primarily on patient safety, but in this moment with this disease, we have a particular responsibility to really focus on the safety of the staff involved as well. And when we're taking care of a patient with a highly contagious illness, we can't simply wing it in the moment. We really need our team to feel prepared, and that takes planning and practice. You can go to the next slide, please. So when Considering planning this, I teamed up with our FEM fellows and an anesthesia fellow. We also immediately engaged leaders of the NICU, the well baby nursery, our postpartum areas, as other important stakeholders in this plan. We wanted to start by creating and testing the workflow of a C-section patient with COVID and use this as kind of a 2-for-1 project. We would develop the plan for getting the patient to the operating room and safely delivered, and then use that model to do repeated simulation. As you start to consider the idea of moving a potentially infectious patient from a delivery room or a pre-op space to the operating room, while still trying to safely incorporate donning and doffing of PPE and conservation of PPE, you begin to realize quickly the complexity of that and all of the moving parts. And that's when it becomes obvious that you really do need a predetermined plan, and why we'll have to practice with the staff to reliably execute that in a real scenario. We kept our scenario very simple. This was a scheduled repeat C-section patient who screened positive for symptoms suspicious of COVID-19 at the point of registration. The simulation took place on our labor and delivery unit. And we chose to run the first attempt on a Sunday morning, hoping to have a relatively low census. And of course, that can't work out as planned. The place was absolutely busting. And we had to just move forward because we had multiple leaders of departments coming in on their day off to help roll this out with us. You can move to the next slide. This next slide that you'll see is the model that we have developed. It's quite busy and complex, so I'm going to refer you to one of the later slides. Has information about an article that we've recently released around the details of this work, but extremely briefly, introduction, the MFM fellow that I worked with, Dr. Gonzalez Brown, basically took 2 other models that were being developed on the West Coast where they were encountering this before us here in the Midwest, sort of tailored those into something we could use within our specific unit. And then developed this. This is like no other drill I've been involved with in the past, because this wasn't so much a drill as you think of, as it was a slow motion kind of walkthrough. I think a drill is effective for demonstrating a team's expert knowledge of a process already in place. But this was more like a rapid PDSA cycle. So we didn't want any surprises. Plans for this drill were announced in the morning, so everyone knew that this was taking place. With already kind of high tension levels right now in the unit, we didn't need them to feel caught off guard. We assembled a relatively large team, including department leaders, for that first simulation, handed everyone a printed copy of our draft, and basically reviewed it and altered it as we walked through that first sim. We engaged a few staff members from each area to participate and play their respective roles. That gave them opportunities to make suggestions into the model and also to practice at the same time. I'll very briefly pause here to say that we did not, we used no actual PPE or sterile equipment in an effort to preserve all of that. So staff were asked to kind of state what they were doing in the moment, and that's probably another significant difference. Each time we drilled, when I talk about this PDSA cycle, we would make small changes to the model and try to rerun it again the next time. And essentially after 4 to 6 or so revisions, came to a final product. You can go on to the next slide. As with any project such as this, we found some barriers and obviously successes in this plan. There were disagreements from some of the staff and providers about the workflow itself, and I think that was important to find that out during the simulation process. As always, in a multidisciplinary setting, there's a number of competing opinions and agendas, and at some point, it's important during that simulation to determine what parts of the workflow, if any, will be negotiable. For us, we determined, and once we had our final product, we had to basically say to the group, you know, I hear you, I understand it's outside the norm, but this is the model that we're deciding on. Additionally, we had concerns about taking staff out of their normal patient care routines, but this was prioritized as very important information to share with everyone. And finally, in an academic setting, the resident turnover into the area definitely adds a different dimension of trying to ensure that everyone knows that information. We learned some important lessons along the way. It's complicated already. We don't need to complicate that scenario any further by adding a stat kind of situation to it. I would recommend that you practice with your staff a very routine type of C-section first and get that kind of routine down before you would move to something that feels more emergent. And again, because you can't guarantee that when this happens in real life, that very same group is on, you need to ensure that you share this information regularly with staff who are coming on through intermittent shift huddles or newsletter communication. And certainly if there's a COVID positive patient on the unit, review that information with the staff who's on. I think comes some of their fear of the unknown. I think being part of the original design gave them some sense of control. Information is power, and I hope we empowered them to feel more confident. Of course, there were moments of fumbling along the way, and watching, your own perinatal safety nurse wander through the hallway in a gown and socks on the way to the OR is good laughter and medicine in that moment. That was a good break. And finally, I'm happy to say that despite the crisis, we're building our team culture. It's been interesting to see that even as we're encouraging safe distancing, the individual parts of our team are growing closer. And I hope as this crisis settles, we'll take that as an added bonus with us into the future. My last slide is the title page of the article that we've just published regarding this work. And again, I appreciate the opportunity to share this all with you. I hope you're all staying healthy and you're obviously taking fantastic care of your patients. I'm sure we can this crisis. Thank you so much.
Oh, Heather, thank you. That was wonderful. I truly appreciated, especially the analogy of the rapid cycle PDSA and this just being an uncharted territory here, and looking at it as a drill. Very helpful feedback. We will definitely be certain to post these resources on our website. I know we've gone over a couple of minutes here, and I'm so grateful that the vast majority of people have been able to stay on. Just so much great content today. Very grateful for our presenters. I'll quickly go through the last slides here. We'll go ahead and put a plug in for our next week's webinar. This will investigate the impact of racial disparities for the pregnant patient, and then also something I think that everyone is looking for, supportive measures for caregivers. That we'll tackle both those topics next week. On the next slide, we'll go ahead and see everybody's, all the presenters today, their contact information should you need this. This will be on our website. If you look at the next slide, we will be posting the slide deck and the webinar link on our website. This is the registry info that Dr. Marcotte and Dr. Kaplan covered. Again, very important to go ahead and be able to participate in this if able. Data is definitely powerful here, and we want to learn from that. On our next slide, I just want to go ahead and we could go forward one more. Thank you from all of us at OPQC. We're so grateful. I want to echo Heather Lortz's words, just in awe of all the work everyone is doing and coming together and all teaching, all learning together. We're very, very appreciative for all of that. And lastly, we'll go ahead and take good care out there, and hope to talk again with you all next week. Again, stay safe, be well. Bye-bye.